Hello, everyone. We are going to wait a few moments to let people log on to the webinar, and then we will get started. Hello and welcome to the Myositis Association's Ask the Doc webinar series. This series is created in order for you to access global myositis experts and have your questions answered in a way that maybe you can't with your local provider. Maybe they aren't as well versed on myositis as you would like, or maybe you're just in between appointments and you have a burning question. I'm so excited today that we have Ask the Doc Geneticist edition with Dr. Janine Lamb. Dr. Lamb is a professor in complex human genetics and genomics at the University of Manchester in the United Kingdom. Her research aims to improve understanding of the causes and pathogenesis of myositis so that we can better characterize individuals and improve the evidence base for stratified treatment and improve health outcomes. Dr. Lamb is also a member of TMA's Medical Advisory Board. Welcome, Dr. Lamb.
Thank you, Rachel. Thank you.
One moment, I'm going to bring you up. There you are. It's so good to see you. If you want to take a few minutes and just tell us a little bit about your work.
Yeah, great. So thank you very much for that kind introduction. It's great to be here today. Good afternoon, good morning, whatever time you're at in the US. As Rachel's just said, I'm Dr. Janine Lamb from the University of Manchester in the UK. I am a geneticist or an epidemiologist, so I should just preface this session with the fact that I'm not a clinical doctor. So I'm not a dermatologist or a rheumatologist or a neurologist. I've been working now researching into myositis for over a decade at the University of Manchester in the UK. And we have a great team within our Manchester Myositis Research Group. So I work with an active team of people who are clinical doctors, neurologists, dermatologists, rheumatologists, and then we have, clinical research fellows, basic scientists, PhD students, research assistants. So we have a great, vibrant team at the University of Manchester. And I suppose we're all trying to tackle myositis from different angles, just to increase understanding of the disease. So where I am coming from as a geneticist is that I'm hoping that by understanding genetic risk factors that increase risk of developing myositis, that we'll be able to better use this knowledge to identify different subgroups of individuals. And just to sort of briefly outline what I think is important about studying genetic risk factors for myositis, I'm hoping that we can identify genetic similarities or differences between different individuals, and that might be different clinically defined subgroups of individuals. It might be individuals who have different autoantibodies in myositis, and that will tell us something about how the genetics and the clinical definitions or antibodies are related. I'm hoping that by understanding something about genetic risk factors, we might be able to tell how myositis relates to other immune or inflammatory disorders. That if we can understand something about genes or genetic variants that increase risk, it might tell us about the biological pathways that are involved in the disease. And then if we can understand something about maybe environmental risk factors as well and how they relate to genetic risk factors and how they might interact. And then I'm hoping that ultimately this knowledge of genes and biological pathways might suggest new therapies, or it might identify people that are more likely to respond to one therapy or another, or those who are more likely to respond better. And that it might act as a possible biomarker of disease, a prognostic biomarker or a diagnostic biomarker. So I haven't prepared any slides today. I'm delighted to be here, but that's hopefully just giving you a bit of a potted overview of where I'm coming from.
Thank you so much. And thank you for participating in this today. We are so happy to have you share your expertise with us. I'll go ahead and get started with our pre-submitted questions. If you have a question for Dr. Lamb, you can put it in the Q&A box at the bottom of your screen. So Dr. Lamb, we've heard that polymyositis is considered not actually a myositis diagnosis anymore. Is there anything genetically that supports this? Can genetics tell me what I have if it's not polymyositis?
So that's a great question, and I suppose so. When we talk about genetics and myositis, we're talking about risk factors that might increase your risk of developing disease or increase your predisposition to disease. So myositis, we don't think these are genes or genetic variants that cause disease. So these variants would be present in the normal, sort of the healthy population, but they just might be at a higher frequency in people with myositis. So we know what we're trying to do is look for genetic differences between different clinical subgroups. And we do see that there are some genetic differences between individuals with polymyositis or immune-mediating necrotizing myopathy or dermatomyositis. Even though, as I've said, I'm not a clinician, people now sort of think polymyositis is kind of what's left once you've diagnosed people with other forms of myositis. Ironically, from a genetic perspective, we actually get a much stronger genetic signal in the polymyositis, patients with polymyositis. So there's a particular region on chromosome 6 called the HLA region, where there's lots of genes that are involved in immune response. And we get a very strong signal, particularly in polymyositis in the HLA region. So we think in polymyositis that there might be more of a sort of a pan-autoimmune disease risk there in polymyositis. So no, we can't say you have a particular genetic variant that defines what kind of myositis you're going to get. That would be the holy grail. But it might tell us something about what kind of myositis you're more likely to have.
In your bio, it talks about stratified treatment. Could you elaborate on that a little bit?
So we know, for example, that in dermatomyositis, some individuals have a cytokine in their blood, something called interferon, and they're likely to produce higher levels of interferon in their blood. And we can also see that there are genetic variants in interferon genes that are involved in patients with dermatomyositis. So if you could do some kind of genetic test or a test for interferons in the blood and show which patients had higher interferons, and you might be able to target those individuals with a JAK-STAT inhibitor, for example. So that's sort of what we're hoping to move towards, a sort of a more molecular diagnosis of disease rather than that's what I'm hoping to move towards as a geneticist or a molecular biologist, is a more molecular-based stratification of patients rather than based on a simple kind of clinical diagnosis.
This person's been diagnosed with sporadic IBM and their father had it also. Genetic testing has all been negative. Any suggestions of follow-up testing? They would like to know if their kids are at risk.
So again, another great question. So in short, in terms of genetic testing, the answer is, I suppose, no, because as I've just said, there isn't a causal relationship between having a particular genetic variant or variant and getting disease or getting IBM. There were some really nice studies that came out of Sweden. So they have this fantastic resource in Sweden called the Swedish Healthcare Registry, where all individuals in Sweden are registered from birth right through to death. And so every time they go to a pharmacy or a pharmacist, every time they go into hospital, every time they visit their GP, it's all recorded like throughout their life and follows the whole population in Sweden. So what they were able to do in Sweden, using this really nice Swedish healthcare registry data, is that they were able to take all the individuals in Sweden that had myositis, and then they were able to look at the first and second degree relatives. So that's a first degree relative is a sibling or a parent or offspring. And they were able to look at the first or second degree relatives and see if there was an increased risk of myositis or an increased risk of other related rheumatic diseases or autoimmune diseases in individuals with myositis. And they did find that there was an increased risk if you have myositis of having another family member with myositis. And that risk was about 4 times the risk compared to somebody in the population that didn't have myositis. But an increased risk of 4 times sounds like a lot, but because the relative incidence of myositis is very, very rare and very, very low, then it still doesn't translate into a very high absolute risk because the numbers are still very, very small. So individuals with myositis, there is more myositis that runs in the families, but the absolute numbers are still very, very small because it's a very rare disease.
Based on what you've said, is there any value in a myositis patient having their genome sequenced?
Because we don't think there's a single genetic variant or single genetic variant or gene involved, that wouldn't give us any definitive answers. I think the cases where that might be of use is if there is a misdiagnosis or a differential diagnosis. So if somebody has been diagnosed with myositis, whereas actually what they might have is a metabolic myopathy or a muscular dystrophy or a genetic myopathy. So I only know things from a sort of a UK NHS perspective, and I suppose neurologists then, if they are having problems identifying a diagnosis, might get a gene panel done looking for causes of muscular dystrophy or metabolic myopathies or other myopathies to rule out those disorders. So I can see in that instance it might add some value, but because there isn't a gene or a variant for myositis, in that case, getting your genome sequenced won't give you any kind of definitive answer.
Thank you. Why do women have a higher incidence of myositis except for IBM?
So again, that's a really great question. I think one that's been like taxing geneticists and other researchers for a long time. And I think, in short, the answer is we don't know. In myositis, well, this phenomenon is not unique to myositis. We see it in a lot of autoimmune disorders, a higher incidence in women than in men. So the same in systemic sclerosis, the same in Sjogren's syndrome, systemic lupus erythematosus, the same as celiac disease. So it's not unusual at all that in dermatomyositis or polymyositis in inverted commas that there is a higher incidence in women than in men. I think one of the factors that has been suggested for decades was the role possibly of different sex hormones, so hormones that were different in women to men. But this doesn't really get a lot of support because you're still getting an increased incidence of dermatomyositis or polymyositis in postmenopausal women, for example, when you would expect there to be less of an involvement of sex hormones. So there isn't a lot of support or conclusive support for that as an answer. The other thing that people have suggested is that it could be a role of the X chromosome. So women have 2 X chromosomes and men have 1 X and 1 Y chromosome. So the suggestion has been that in women, there might be a gene or genes on the X chromosome that increases risk, and that might explain why there's a higher rate in women. But again, we haven't found any conclusive evidence yet. There are suggestions that there are some genes on the X chromosome, like toll-like receptor 7 and 8, that might be involved. But we don't really know, and conversely in IBM, there is the higher incidence in males, and there's a higher incidence in males of other disorders like ALS as well. And again, we don't know the reason why there is a sex difference.
Can your work shed any light on why people of color have a higher incidence of myositis and why it is worse for them?
I think unfortunately, at the moment, that is not something I have properly been able to explore, and it's definitely as a myositis consortium, myositis genetics collaboration is something that we definitely want to explore, and we need to get some more funding and some more grants to do much larger studies, because I think the studies so far in women of color or people of color have been smaller than white individuals. I think and so this is somewhere we really want to go in myositis. In other disorders like systemic lupus, erythematosus, and rheumatoid arthritis that are more common than myositis, they're ahead of us in this kind of research, and they've been able to start doing a lot more what they call trans-ethnic or trans-ancestry analysis, so trying to look at how myositis differs between individuals of color from a Black background, Asian background, white ancestry, and trying to do those kind of comparative analysis and trying to understand. I think, so as I've just said, myositis is behind the field, unfortunately. What has been interesting over the last few years is that there have been some studies now starting to come out of China and Japan, where they've looked at individuals with myositis. And interestingly, in Japan, what the studies there showed was that this region of chromosome 6 called the HLA region, which has a lot of immune genes involved in immune response, they didn't actually find any signal there on chromosome 6 in the HLA region. So that contrasted very strongly with individuals with white ancestry or European ancestry. And so this is something we definitely want to explore. We need to get some funding. I think it's a really important research question to be able to look at different people of different ethnic backgrounds or different geographic regions.
Are there differences genetically between juvenile myositis and adult myositis?
So again, I think we need a lot more research here. And historically, we've taken a bit of a sort of a polarized binary view. So we've tended to look at like juvenile onset dermatomyositis and then compare those individuals to adult onset myositis. And what we need to be doing is a much more nuanced approach, where we're, instead of treating it as some kind of binary juvenile onset, adult onset, looking at age stratification and including age as a covariate in our analysis, so looking right across the lifespan or across different ages. There has been some research where we have found that associations in the HLA region on chromosome 6, that they do differ between juvenile onset dermatomyositis and adult onset dermatomyositis.
And Dr. Lamb, is that why people that are diagnosed with juvenile myositis retain that diagnosis even after they are technically an adult over 18?
I don't know the answer to that, actually. I don't know. Something else that we're very interested in exploring from a sort of a genetic and an environmental point of view is that we know that there's an autoantibody called anti-TIF1 that's very common in juvenile onset dermatomyositis. And it's also seen in adult onset dermatomyositis, but particularly in individuals who are more likely to get cancer-associated myositis. So we have tried to look at genetic differences in individuals who have this anti-TIF1 autoantibody, but to try and look and see if there are differences between juvenile onset dermatomyositis and adult onset dermatomyositis. And we do find that there are some differences there. So, this might, I think they're very sort of exploratory results so far. We need some bigger numbers of individuals to really kind of robustly replicate the data and see if there really are differences there. But that's something we definitely want to look at.
Why is IBM so different from other forms of myositis?
I think that probably is a question better directed to a neurologist or something rather than me.
We can move on to another definitely genetic question. I've got, is there any genetic association to help us know if viruses like coronavirus or their vaccines will stimulate myositis?
So I think in short, the answer is no. I think, again, that's a really underexplored area of research. So I think Fred Miller and Adam Schiffenbauer's group at NIH have done some lovely work in the past and ongoing on environmental influences in myositis. And I think being able to do a lot more research on how environmental risk factors might interact with particular genetic risk factors in increasing risk of myositis is something that would really be worth doing. I think, again, this is a question of funding and really generating the data from individuals who are within the Myositis Association. So I think it'd be fantastic to have a patient questionnaire on history to viral exposure history, for example, and then to be able to use that data to actually be able to integrate it with genetic data to see if it can tell us something about whether there's a viral genetic interaction. But the trouble is actually collecting that sort of data is very, very difficult because it's reliant on individual recall of what viruses you've had, when you had them, knowing what viruses you've been exposed to. So we don't know the answer yet, but I think having a data set that has from individuals who have myositis, where we have genetic data, but we also have a full history on sort of viral exposure or something would be a fantastic resource.
Well, I do know what with how well my memory does or doesn't work. There could be some question about the validity of the self-reporting, as you said. I don't remember when I had what or for how long or when it started. So, but it does give us a starting point to look at the data. There was a recent article from Karolinska Institute that found associations between genetic markers with myositis autoantibodies. And can you comment on this? Is this a new way of classifying IIMs? Is there reason to believe this could refine treatment protocols? And what does this tell us about the underlying pathophysiology of these diseases?
Wow, big question. So I guess, as I've said, that's what we're hoping to move towards, being able to understand genetic risk factors and how they might be similar or different between individuals with different autoantibodies. there are a number of studies now which support that kind of line of argument that the genetic risk factors are different in individuals who might have, for example, a JO1 antibody compared to HMGCR autoantibody compared to a TIF1 autoantibody. So, but we don't know why yet those genetic associations differ. It might be that again, it's this region on chromosome 6, the HLA region. The genes in this region, what they do is they present proteins or foreign proteins to the immune system. So it might be that these different HLA genes recognize different proteins that they see as foreign and present them to the immune system. So that might be why there's different HLA associations in different autoantibody subgroups. In terms of refining treatment protocols, I think that's really too early at the moment. The best we can do at the moment with the sort of serology data is use it to kind of predict what kind of myositis people might get and how their disease might develop. And I suppose someone like Sarah Tansley at the University of Bath, who does a lot of research on myositis serology, I think it's now a great diagnostic tool, autoantibodies and myositis, and does tell us something about which people might be more likely to develop lung disease or to have a better or worse prognosis. But in terms of actually integrating that with the genetics at the moment, I think it's still a little way off being able to use to refine treatment protocols.
Is there any thought that a person has had myositis much longer than what literature is saying? My immune system went into overdrive at 48 with many autoimmune diseases, and I can go back to childhood with myositis symptoms.
I think all the individuals here on this call will know very well that because myositis is rare, it's not very well recognized, certainly in primary care by your GP or your primary physician, and that often people will take years to get a diagnosis. So I think there's certainly a problem of recognition, but I don't know. We think that people have a genetic susceptibility or predisposition, and then there might be some kind of environmental trigger that then triggers the development of myositis, and that trigger could be a virus. It could be some kind of exposure to silicon, asbestos, occupational exposure at work. It could be like a statin, so some kind of drug. So I think it's entirely plausible that you could have had sort of symptoms that were myositis that you've had for years before diagnosis.
This person has statin-induced myositis, though HMGCOA antibody is negative. What tests could I have to look for genetic risk factors? This would support my diagnosis, as some doctors have doubted it.
I think that's a really interesting question. Professor Andy Mammon in the US has carried out some lovely work on particularly on HMGCR positive statin associated myopathy, and we know that there is a particular genetic association there in people who are HMGCR antibody positive, and we think that genetic association is different in people who have adult onset HMGCR antibody positive compared to juvenile individuals. But what we don't know yet is whether people who develop HMGCR autoantibodies, but are statin naive, whether they differ genetically. So sorry, this individual said they are HMGCR negative. Is that correct?
Yes. Statin-induced myositis, but HMGCOA antibody is negative, is what they have on here. And they also wanted to know if they do have a gene that is a risk factor, would it be helpful for their relatives to have the same test done when they need a medication to lower their cholesterol? Or would their insurance company, and I know you can't speak on behalf of insurance companies, but is it possible that they would approve Repatha or other PCSK9 inhibitor medication to lower their cholesterol and cardiovascular risk just on the basis of having a relative with statin-induced myositis?
So I certainly can't comment on health insurance company screening.
Especially across countries.
There are so anti-HMGCR positive autoimmune necrotizing myopathy is a different clinical disorder to statin-induced sort of myotoxicity, where somebody gets a adverse response to a statin that then resolves when the statin is removed. And there are genetic variants that some genetic variants that affect the way that people respond to statins, and whether they are sort of fast metabolizers or slow metabolizers. But as I've just said, the sort of statin-induced myotoxicity is a different sort of phenomena to autoimmune, immune-mediated necrotizing myopathy.
Well, I have one final question for you. In your field of work, what are you most excited about the future?
Gosh.
I didn't even prepare you for that one, sorry.
I think it's a really exciting field to work in, because it's challenging and there's many different angles that we're all trying to work together. I think it's a fantastic collaborative environment to work in as a researcher, because it's rare. Everybody worldwide really works together and collaborates, because they're all trying to tackle the problem from different angles to find solutions for better patient care, better treatment. So I think there's many. I think the integration of serology with genetics, trying to get hold of more sort of environmental data. Yeah, there are many angles to the field that kind of excite me, and certainly we've got a long road ahead of us, I think, to try and tackle this disorder. So.
How did you get involved in myositis research in the beginning? To start with, what drew you to that particular?
So I'd done my PhD in genetics, and I think because this is such a sort of under-researched area, I think there's a real sort of opportunity there, or a challenge to try and
For sure.
make a difference, and to feel that you could kind of contribute something. I think that the heterogeneity of the disease, as we've just been talking about, with these different clinical subgroups, different autoantibody subgroups, the fact that you've got juvenile and adult onset, makes it a very fascinating, challenging area to work in. So, yeah.
Well, thank you so much for participating in our webinar today. We appreciate the work you do for myositis, and we will say some prayers and wishes into the universe for more funding, since that was a common theme. But we really do appreciate you. Thank you so much for being here.
No, thank you for having me today, and I hope I've been able to answer some of the questions that have come my direction anyway. So.
Well, our members are really advanced. They are definitely experts in their lived experience, for sure. So All right. Well, thank you. And for those of you in the audience, thank you for joining us today. Join us this Thursday for another webinar, TMA Empowerment Clinic, Patient Involvement in Research. So it is tied. Do you read myositis research reports and think this is nothing like what I live with? This is not surprising, since doctors, health professionals, and researchers know an awful lot about myositis, but they don't know what it's like to live with myositis. You, as a patient or as a loved one of someone living with myositis, do have valuable firsthand experience with this disease, and there are ways you can contribute to this experiential knowledge, to research efforts. So please join us this Thursday also at noon with Ingrid de Groot, myositis researcher and patient, and we will delve into the topic of how you can get involved to move the needle forward. Thank you, everybody.